Sexual dysfunction. So you can pause this video if you want to take time to review anatomy and physiology of the female reproductive system. This also includes breast tissue. You're going to need to know the different parts and functions of those as well. So we're going to start with disorders of the female reproductive system. The first disorder we're going to talk about is breast cancer. Now, breast cancer, as you can read here, affects both males and females. Overwhelmingly, 99% of cases are in female. So some risk factors: being female, over the age of 50, being white or Caucasian, having a family history of breast cancer, especially in the sister or mother. Personal medical history of cancer, including breast, endometrial, or having proliferative fibrocystic breast changes, starting menses before 12 years of age or menopause after 50, the first birth of a child after 30 years, prolonged use of estrogen replacement therapy. That's just because a lot of cancers are driven by estrogen, not all of them, but a lot of them are. And then having x-rays or other radiation before the age of 30, and then lifestyle factors that include 2 alcoholic drinks per day, obesity, smoking, high economic status, and breast trauma. So you can see there I've got a picture of the anatomy of the breast. Your textbook also has more risk factors. And also important to note that breast cancer, the reason why we're hitting it so hard here is because it is the second leading cause of death in females, of cancer deaths in females. First would be lung cancer, which metastasis of breast cancer often goes to the lungs. So pathophysiology of breast cancer. So what is the disease process of breast cancer? As I've talked about before, cancer is an irregular, abnormal growth and replication of cells. So all cells in your body have a job to do. And then they are also regulated so that we don't have too many of them growing at one time. So when those factors fail, you have cancer. So these cells stop looking the way they're supposed to. They stop, their structure is different. They stop functioning the way they're supposed to function. And then the things that are supposed to regulate how much they replicate are also failing. So you have growth, abnormal growth of cells that aren't doing a function and are actually taking up a lot of energy, a lot of perfusion. They tend to be very vascular, these tumors, and they become their own tissue that has no function, and it starts disrupting other places of the body. Most often, breast cancer starts in the mammary ducts. And like I said before, rate of cancer can depend on hormonal influences. Remember that estrogen that I had talked about, that can really drive cancer. Cancer can be classified as invasive or non-invasive, just meaning, is it in the duct or is it going outside of the duct? So if it's out of the duct, then it's invasive. It's going into other tissues. If it's non-invasive, it's staying in the duct and it's not invading other tissues. Clinical manifestations. So let's look at some assessment findings we're going to have. Most often you're going to have a lump in the breast. It's going to be usually described as something hard, round, maybe lumpy inside the breast tissue. Most common site is going to be in the tail of the breast, which is towards the axilla, and it may change the size or the shape of the breast. So there's different things that we look at that can contribute to these or have an explanation for these as well. We don't want to just jump to cancer, oh, it's cancer if you have a lump. No, it could mean we have an infection. You might have a mammary duct that has an infection. It got contaminated somehow. We really hear about those with, during breastfeeding or lactation. That can also explain, breast change in size and shape during pregnancy and lactation. Nipple discharge. So if you have none of those things going on and there's nipple discharge, that is a huge red flag that there could be something going on. There are other explanations. I did have a friend that had a teratoma, which was her ovary was taking over fetal-like appearance, which they found teeth and hair in her ovary, but one of her symptoms of the vast array of symptoms she was having was nipple discharge while not pregnant or lactating. Breast pain can be there. It is not very common to have breast pain with breast cancer. As you have probably remember from last semester, that a lot of cancers, when you have pain, it is typically a later sign of cancer. Persistent rash, flaking, or eruption near the nipple area, or a place or a sore that just doesn't want to heal. Those are also signs that could be breast cancer. And then if the breast tissue takes on a texture like an orange, they call that pude orange. just meaning that that is taking on that weird kind of texture. So early detection and screening. So the least invasive one is going to be the self-breast exams. These are how most breast cancers are usually found. Around the age of 20, women should be encouraged to do breast exams monthly. You can do them laying down on the bed. There's all kinds of pamphlets on how to do these, or if you forget while you're laying down, then try to remember to do so in the shower, something like that. The best time to do a self-breast exam was going to be at least 1 week after your menses. When it's coming close to menses, and even during menses, breast tissue tends to change. It gets a little lumpier. So it's not always good to go by that, but breast cancer, during menses. Let's wait a week after menses and see if that does go away. And then refer to your book on how properly the technique and everything of doing that breast exam. So clinical breast exams, these are when you actually go to a doctor or nurse practitioner or PA or whoever it is for your kind of annual physical. At least every 3 years, a breast exam needs to be done starting at the age of 20. And then when you hit 40 years old, then the breast exam should be annually. This changes, due to risk factors and that kind of thing. If there's a family history of breast cancer, they're probably going to do annual checkups and that kind of thing. So mammograms, a baseline should start somewhere between 40 and 49 years old. And then we want annual mammograms done at the age of 50, just because the risk of cancer goes up exponentially at that age. Mammograms, I have that picture up there. With a mammogram, the breast tissue, because it is so dense with the mammary glands and the mammary ducts and the blood vessels and the skin, the tissues are just very dense, very hard to see through. So the breast tissue has to be squished very, very flat in order to see through it. And so that's what that machine is there for. And it can be pretty uncomfortable. There's different types of mammograms available. Some of them have more radiation than others. Some of them have more imaging than others. But they're all doing pretty much the same thing of getting a visualization of the inside of the breast tissue. Other diagnostic tests that can be used, ultrasound. So if there is a problem point that they found on the mammogram, then they can go in and do an ultrasound to really kind of take a look at what it is. Usually they can see, is it dense, is it opaque, or is there fluid inside of there? If it's fluid, then it's probably a cyst. Usually cysts tend to go away after the next menstrual cycle, so they can get good imaging. And for somebody that has a lump, they get that mammogram, they can see it on the mammogram, they go and they do the ultrasound and just hear, oh, it's a cyst. It should go away in a month. That can be very comforting for a patient. Other tests that can be done, CT, MRI, PET scans, these are usually always done with and without contrast, meaning they're going to insert dye, usually through IV. And with that dye, they're going to be able to see the vascular system. And so if there's cancer in there, a lot of dye is going to light up in one particular spot, because cancer tumor tends to be extremely vascular. So things that we need to know, like, are they allergic to shellfish? Do they have iodine allergies? Those kinds of things that we're going to have to ask about. Cytologic examination of the fluid or nipple discharge. So if there's any kind of that going on, or that sore that just won't heal, we'll take a sample of it, send it to a lab. Sometimes they can see those abnormal cells from there. We can also do biopsies. So typically the first line is going to be a ultrasound guided needle biopsy, meaning that they're going to use an ultrasound to visualize that lump, go in with a very large needle and aspirate. So, suck cells into the syringe. And then excisional, just, a lumpectomy can be done here, where they're going to go in surgically and remove that lump and then send that on and see what those cells look like. So staging of tumors, this depends on, the size of the tumor, the lymph involvement, and if it's metastasized, meaning has it spread to other tissues. Breast cancer tends to want to go to the lung cancer, or tends to develop into lung cancer. Those cells migrate from the breast tissue through the lymphatic system into the lymph nodes, continuing through the lymphatic system to somewhere else, and it typically wants to land usually in like the lungs or something like that. So one of the screenings that you can do, it's very hard, but they call them subclavicular nopes. So if you feel under your collarbone and if you have any lumps in there, that can be suggestive of some kind of breast or lung cancer going on. Usually you should not feel those nodes in there at all. So treatment for breast cancer, tamoxifen, this is going to be an important drug to remember. This is an anti-estrogen medication or hormone therapy medication. So like I said, a lot of cancers are driven by estrogen. So if this is a particular cancer that is driven by estrogen, by taking tamoxifen, we are getting rid of that extra estrogen that's driving that cancer. Chemotherapy and radiation are also very common. We talked about chemotherapy last year, how it broadly affects cells. We're getting more specific with it on what cells it's targeting. Still not there yet. That's why you have hair loss and the immune system goes kaput and lots of other health issues associated with chemotherapy, because it is a broad treatment to try to kill as many cancer cells as possible. Radiation can be more pinpoint to shrink tumor and kill the cancer cells that way if it has not metastasized through the body. Port placement is usually very common. That's what that picture is there, for quick and fast, easy IV access. And then surgical. With breast cancer, we have 3 main types of surgeries. So the radical mastectomy is going to be everything. The breast tissue, the muscles under the breast tissue, way up into the armpit. I mean, the entire pec area is gone. The modified radical breast mastectomy is going to be sparing the muscle and just taking the breast tissue. And breast conservation surgery, they're going to try to conserve as much breast tissue as possible in order to maybe do reconstructive surgery or something like that. So post-op care, one of the priorities is going to prevent lymphedema. So usually with those mastectomies, they're going to be taking some lymph nodes. They want to see if this cancer has spread. The lymph nodes are going to tend to be in the arm, the upper underarm areas where these lymph nodes are, that they usually want to take out. So a problem with that is these regulate where the lymph is moving, and if they're gone, then they're not able to do that. You can have a buildup of fluid called lymphadenopathy, as you can see in this bottom picture with the hands. And I know quite a few people that have this, that they just have this recurrent huge amount of fluid building up in their arm because of the lymph nodes that were removed. And so this is the normal arm. So rules, this is why we don't do blood pressure. We don't do venipuncture or anything on that affected arm, meaning the arm with the side of the mastectomy. It is very common for people to have drains. These drains are called JPs or Jackson Pratts. They look like little grenades. I kind of talked about them last semester. You kind of compress them down, hook them up, and then they just kind of suction any fluid that's in the surgical area. And then a hemovac is going to be like an accordion type thing that's squished flat, and then as it tries to expand, it's going to bring extra blood into it. We're always going to be assessing for excessive bruising, infection, that kind of thing. Pain is going to be high on the priority list. Exercises, just doing range of motion. We're not going to have them do any heavy lifting or anything like that. Psychological care is going to be extremely important here, especially that body self-image disruption, or disturbed. Losing breast tissue can be extremely traumatizing for a female. They may not feel like they're a woman anymore. They may be concerned about how their significant other is going to see them. Maybe this is a childbearing age person, and she's worried about being able to breastfeed her child. There's all kinds of different things that they could be going through. So really important to remember those communication techniques and just sit and listen and provide counseling as needed. Okay, this concludes the first video. Continue listening in part 2.